All right. Hello, everyone. I hope you're doing well. Thanks for coming online tonight. We'll get started here in just a little bit. We'll get some more people in the room. If somebody can chat me, can you hear me okay? All right. Awesome. Thank you. And you can see the slides okay too, I hope. All right. Awesome. We'll get something to drink, stretch out a little bit. We got a couple minutes. We'll get started right at the top of the hour, so we keep you on schedule, okay? All right. Yeah. Thank you for coming online tonight, everyone. We're going to keep letting some people into the room. Got a couple minutes. Thanks to all of you for getting online tonight. I know you got a lot of other things you could be doing this evening. Appreciate you being on. And we're going to talk some neuromuscular here in just a little bit. All right, we're gonna get started in 1 minute. All right, we got a couple more people coming into the room here, and I'll keep tabs on that to make sure we can let other people in as they're coming. All right, share with your friends if you let them know. We're at 40. Let's see if we can break 50. That'd be cool. 60. Just depends on the topic. It can get all over. So, all right, what's the top of the hour? I need to respect your time. My name is Scott Shaffer, Dr. Shaffer. I'm going to do the class today. We're going to talk about neuromuscular pathologies. Before I just start rambling on here, go ahead and chat in for me. When do you plan on taking the exam? What month are you taking the exam? A lot of Julys in there. All right, we're getting people. Yep, some Octobers. Very cool. Good. So we got some folks that are getting ready, getting close, right? And a mix of other people that are taking it. Yep, in different months, and this is good. This is a great spread. For those of you who are just coming online, just chat in when you plan on taking the test. That's great. It's good. Gives me a good idea, kind of where people are at. All right. Let me ask this question too. How many of you have taken a practice test, a full practice test? Yeah, throw it in there. Yeah. And if you haven't, not a big deal. Okay, you're okay. but I'm just kind of getting an idea. That way, when we're talking about questions, it gives me an idea where you're at. All right. Oh, we're so close. We're at 49. Let's see if we can get two more. There we go. We might be there. Right on. Okay, very cool. All right, mini test. So some have taken kind of partial exams, or taken, some of you have taken full exams. There's no right or wrong answer. It's really dependent on what date you're taking it, and kind of backward planning from there. Yeah, we got some people getting ready to take their first here in a little bit, practice test, which is cool. So a little bit, we're going to touch on neuromuscular. We're going to stay neuromuscular pathology. Some of this is going to kind of get into musculoskeletal a little bit. Some will, but a lot of the purpose, hopefully, at the end of this, is you walk out and go, I feel a little bit better about kind of the compare and contrast against all these different off of different neuromuscular conditions. That's kind of the goal of what we're going to do today. So I'm going to just again, my background, again, very fortunate. Like you, I applied to PT schools all over, and I was really fortunate. I got into a program called the Army Baylor program here in San Antonio, Texas, where I live now, and was a student there, and joined the Army, and just had an incredible career. And I thought I'd kind of do my initial commitment, and I'd go back to where I grew up in Nebraska. And I just 27 years later, I retired from the military, and so I practiced in a military setting. Went back and got 3 degrees through the military, which was very cool, to include a PhD at University of Kentucky in adult neurological disorders and aging. So I teach a lot of neuroscience. I teach neuromuscular evaluation, and I teach all kinds of neuromusculoskeletal kind of evaluation and treatment. And you're like, why am I talking about this? Just because I feel so fortunate. And what's cool about your career is all of you are getting ready to, get your license, get out there, do your thing. I was a guy in your class that was all about musculoskeletal sports medicine. That's what I was going to do. That was my focus. And about 3 years down into my career, I started to do nerve conduction EMG testing, and it opened my eyes to the nervous system. And then actually went back and got a PhD in adult neurological disorders and aging. So you never know where this cool career is going to take you. And that's the awesome part about it. So, all right, enough about that. Let's get rolling. So, the content, I'm going to touch just a little bit. So all the questions, kind of what we do here is there's a thing called the content outline. If you Google right now, you put 2024 FSBPT or NPTE content outline, you are going to pull up what is on the exam. And this first 2024, this is a new year. Every 5 years, they come out with a new content outline, the federation who writes the exam. And it gives you a rundown of kind of what are the big topics within those areas of the different systems. So I encourage you to do that if you haven't had a chance to see that, because it gives you some good left and right boundaries. We take that, we pull that into our review and study guide book, and it's a good thing to kind of look at as a resource for people. So again, we're going to focus on neuromuscular today. One thing about the questions, those of you that are getting ready to take your first exam, or those of you who've taken a practice exam, those things, you probably have already noticed, or if you've taken practice questions, you kind of notice like these questions just are a little different sometimes. And just to put this in perspective, the Federation is all about producing an exam that attests your safety. Are you a professional, competent, and professional physical therapist? And so a lot of times you're going to get questions on this exam. They're going to ask you about what you would not do, contraindicated, or what's a red flag? What do I need? Do I need to refer this patient? A lot of those questions, right? And those of you who are online who've taken them know that. And so, that's what I would just say. As you approach these questions, just be prepared. Some of these you're going to have to look at it and go, okay, I need to look at this a little differently. What's the most safest option here? And maybe that's my option. All right. All right. So let's do this. Let's get into some questions here. I'm going to start a poll, and I'll put this up so you can answer this question. We're going to do one question at a time. We'll do some different questions here. And I'm running the clock here. I'm going to give you about a minute and 19 seconds is what you're going to have on this exam. All right, poll is up. All right, we're going to go out another 20 seconds, okay? All right. So go ahead and pull in there, folks. We got about 60% of the class that is pulled in. Take a look at those options. All right, another 5 seconds. Pull in there. Take a shot at it. You don't got anything to lose. It's all practice. All right, here we go. We're going to end the poll. We are going to share the poll. All right, I'm going to tell you right now, these are not easy questions, some of these, right? They're hitting on this question specifically makes you not just think about, is it a nerve root problem, radiculopathy, or is it a specific nerve problem like cubital tunnel or a mononeuropathy, but also where in the plexus could this possibly be too, right? So you got to be prepared for those. In this case, what's interesting, right? We got a person who's got significant weakness in their hand to include 3 out of 5 manual muscle testing of all motions of the thumb and finger. So let's look at my hand here. So that means extension, finger extension, flexion, right? That means any motions within the thumb. So when you hear that, that tells you that you've got a lot of weakness in multiple nerves, right? It could be median, ulnar, could be radial, right? All 3 of those big nerves terminally down in your hand are weak. Also tells you you've got this numbness and tingling in a unique pattern. It runs down the medial portion of your arm. If you think about dermatomes, all right, we got dermatome, that's T2, medial forearm, T1, inside of the hand, C8. So now you've crossed 3 dermatomes, or at least 2 dermatomes. You're like, that doesn't fit with radiculopathy. That doesn't fit with just one nerve root, right? That's multiple nerve roots. So in this case, you can kind of cross out C8 radic, because if it was C8 radic, it would be specific. You could still have weakness in those hand muscles I'm talking about, but it wouldn't cross that many dermatomes, right? Cubital tunnel. If it was cubital tunnel, you'd only have, right, ulnar nerve symptoms. So you'd have problems with the intrinsics of your hand, abduction and adduction of your hand, but this patient's having problems with all motions of their fingers. So that doesn't fit either. So we can kind of cross out cubital tunnel. That leaves us with these 2 plexus options, right? What we know about the posterior cord is more C7, right? And so that would give weakness in some of the finger muscles, but not most of them, because your finger muscles, your ability to flex and close your fingers and intrinsically open and close your fingers. When I say open and close, abduct, adduct, excuse me, is more C8T1, right? What is a combination of C8T1? That would be your lower, or your also called your medial, that trunk, or inferior trunk, excuse me. And that lower trunk right there, if you have a lesion here, that's going to be C8T1. It's going to be your medial antebrachial and medial brachial, which would explain that cutaneous distribution, right? And then it's also going to have these extensions, right? You're going to hit the medial pectoral nerve. You're going to hit all C8T1. So that division that comes here into your posterior cord that carries C8T1 is also going to involve some of these nerves too. So this patient is going to have a lot of hand weakness, right? And it's going to, in that lower trunk. So the take home point from this is, if you're getting a question that's involving multiple nerves across multiple dermatomes, more than likely, and it's a peripheral nerve problem, it's not a central nervous system problem, it's a peripheral problem, it probably involves multiple nerve roots or a trunk where those nerve roots come together. All right. So that's a hint when you see those. Let's look at the plexus a little bit from this perspective. If you had somebody who had C5, who had a C5, C6 nerve root avulsion, or an upper trunk, or let's say C5, C6 nerve root avulsion, like Bell's palsy, or excuse me, Bell's palsy. If we're talking about Erb's palsy, Erb's palsy, C5, C6, then they're going to have weakness, right, in all these scapular muscles, because your rhomboid, your long thoracic, they're going to have all this scapular winging. So I always know when I see somebody with a lot of scapular winging and a lot of C5 and C6 distal weakness, the problem's at the root. If I see somebody that has C5, C6 weakness down their arm, and into their pecs maybe a little bit, and into their scapular muscles, their rotator cuff muscles, that's more upper trunk. But if they don't have scapular winging, I automatically know, hey, this is a problem that's more at the trunk. So here's a couple hints about the plexus. If the patient has scapular winging and a lot of C5, C6 weakness and numbness and tingling distribution, I got a problem at the root. If I don't have scapular winging, but I have all those other things that I just mentioned, I have a problem. It's going to be at the upper trunk. And that's how you can kind of divide this plexus clinically. So in a 1 point, you got a minute and 19 seconds on these questions with 45 questions per section, you can get through it efficiently. All right. So that's one example of kind of plexus. So let's talk about some of these other mononeuropathies you might see, right? We talked about let's start with this one. That's classic carpal tunnel. What level of carpal tunnel is that? The fact that we can see atrophy, is that mild, moderate, or severe? Based on the carpal tunnel CPG. Chat in for me. What do you think? Yeah, right on. Severe, 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 right? So that's a hint and a question. If they say the patient's got atrophy in the thumb muscles and they're giving you all these carpal tunnel things, then what are we thinking? We're thinking severe, right? So those are ways and questions they could give you things not only about what's the diagnosis, but what's the prognosis. That's what's evaluation, differential diagnosis, prognosis, patient management. That's all one category of the test. That would tell you that's severe, right? So now what's this patient have right here? This is a real patient. Saw this patient about, I see this about 2 to 3 times a year. And I do EMGs in a busy neurosurgery, neurology clinic. We see a lot of different nerves, right? Which interosseous is that? Good, anterior interosseous. So if anterior osseous nerves involved, right? What muscles does that innervate? That's median, but it's a specific branch of the median, and it innervates your thumb, your flexor pollicis longus, and it innervates your flexor digitorum profundus of your first and middle, your index and middle finger. So you can't go tip to tip. If you look at my finger, I can't. Now, if you do this to yourself, try to pull through. Like you can't. Those are strong muscles. But in this patient, what this patient does on this side, they can't go tip to tip. So they're substituting with ulnar. So they're trying to adduct their thumb, which is ulnar, and then they're just trying to use anything that they can. They're using more of kind of flexing as best they can that finger. And this is weak. If I can pull right through that. That can be because of an anterior interosseous nerve syndrome, or it can be because of a nerve root problem. What nerve root might also cause you to have this same problem with flexing your thumb and your finger? Take a guess. Which nerve root? Okay. Yeah. Keep going. Throw some out there, people. Help them out. Yeah, that's C8. That's C8 all the way, right? That's C8. So that's an example of where you could go back and go, okay, I have to always walk this back. Anterior osseous nerve, yes. But if I'm getting all these other nerve root signs, that could be from your C8 nerve root too. All right. Ulnar nerve. Okay, we put our hands up. And we use everybody, get your right hand up here and do this for me. Flex, you're going to do this. Flex just your last 2 fingers down, your ring finger and your little finger, right? Okay. If the question says patients actively flexing their finger and they show you a picture, they tell you this is what you see. Is this a problem with the ulnar nerve or the median nerve? So they're actively flexing, right? There we go. That's median all the way, right? So we get hung up about this term, the hand of benediction, because we always think, well, what does this mean? And where's this at? And what does this go with? You got to remember the question, they're not out, the board is not out to trick you. Like they're going to describe, is the hand either actively resting or is it flexing? If it's flexing and these 2 fingers go down and the index and the middle don't, that's a median problem, right? If the hand is passively resting and it's curled up like this with this hand of benediction, almost like the fingers are curled down here, and they're contracting and passively down, that's more of an ulnar problem. So always kind of read the question. Are they actively flexing? Or are they not? All right. Awesome. All right, here we go. So number 2, let's go through this. Give you some time on this one. And I'll restart the poll here. Okay, we'll go about another 20 seconds here. All right, we got about 72% that have polled in. Let's go ahead and hit those polls. All right, I'm going to share the poll. All right, so here we go. We got a little spread here. This is, again, not easy question, but you kind of have to work through this history, right? And on the exam, the 24 exam and beyond, now we have nice scenario-based questions. So this kind of gives you an idea of kind of a history that you could put into a scenario-based question. You could ask 3 questions off this one scenario right here, right? So, but we're just asking you one. So what's the differential diagnosis? That's what we're focused on tonight, mostly differential diagnosis, prognosis, patient management. So this patient has intermittent tingling and weakness in violent hands, fingers, and thumbs. They've got this diffuse tingling in their lower extremities and decreased balance. They also, on physical exam, they got ataxia, bilateral Hoffman sign. So they got upper motor neuron signs. They got 3+ patellar reflexes and Achilles reflexes. And again, like I said, when you do the physical exam for sensation, decreased pinprick sensation in bilateral hands, fingers, and throughout the lower extremities. So what does pinprick sensation test specifically? Or sharp? What kind of fiber types? Large myelinated or small myelinated? Yeah, good. Small myelinated, thinly myelinated fibers, which go with which tracks predominantly? Yeah, spinal thalamic. So see how we're tying, right? We're tying all this together. Just think, if you'd have jumped on this a year ago when you started PT school, you'd been like, I don't know where I'm going. But now you're like, I got this, right? It's all this information. It's just a matter of refining it. So let's walk through this. So we've got upper motor neuron signs, right? We got hyperreflexia with the Hoffman sign. In that case, we've got upper motor neuron. We can cross out polyneuropathy. Now, this history has a lot of, it sounds like it could be polyneuropathy until you get to all these things about, okay, now we're getting upper motor neuron signs and symptoms. So again, we can cross out polyneuropathy. Guillain-Barré is a form of polyneuropathy. It's an acute radicular problem. We think a lot about, when we think about, polyneuropathic conditions, we think about this top one, we think about diabetes, think about thyroid disease. It can be from alcohol abuse, renal, right? Those are all chronic polyneuropathic conditions that appear over time. Guillain-Barré is acute, hard, and fast, right? That rapidly pulls myelin off your peripheral nerves all the way up into the root. So it's not just a polyneuropathy, it's a polyneuropathy that also hits the nerve root, radiculopathy. So these patients get weak rapidly. They can get they get some tingling, burning in their feet sometimes, but mostly it's a lot of acute weakness, right? And it happens really rapidly. So this is not happening. No, this is over 4 months. So you can cross out 4. That leaves us with 2, and that leaves us with 3. And good job. We can see majority of people pick between these 2. So you're getting it. You're like upper motor neuron. That's upper motor neuron. This is upper motor neuron. The difference is, what does this patient also have? Is they have tingling and they have sensory loss. Patients with ALS don't typically have it. It's a motor problem, right? And the name says it all. Amyotrophic, which means damage to your anterior horn cell. Lateral sclerosis, that's damage to your lateral cortical spinal tract, or hardening. Literally, the columns get hardened when you go in and dissect out that spinal cord. It just gets, and basically that's what creates your upper motor neuron. So upper and lower motor neuron, predominantly, what do we see? Weakness, fasciculation, spasticity, all those things that can go along with upper and lower motor neuron signs. So in this case, because there's motor and sensory symptoms and upper motor neuron problems, what's most likely, and it goes all the way upper, all 4 extremities, we have number 2, cervical myelopathy. All right. So again, not easy question, but we're kind of working through these diagnoses, right? So cervical myelopathy, we'll talk a little bit about this, but not only, be prepared, and this is a spinal cord thing, right? This is the most common spinal cord thing we see is degenerative cervical spinal stenosis, which causes what? Decreases fluid around the cord, compress into the cord, you get a spinal cord, and a lot of times, depending on the mechanism, if there is a mechanism, and a lot of times there isn't, especially in older adults, 70 to 80s, it just slowly compresses the cord. you're going to often see most commonly is going to be a lot of central cord compression from the front. And you may also see what's called anterior cord syndrome, right? In this case, this patient has a lot of anterior cord symptoms. Got a lot of upper motor neuron signs, also has burning, tingling type things that would go with spinal thalamic tracts. So you can get at kind of, okay, with signs and symptoms, be prepared to think about, okay, well, what are these different tracts? Because if the patient comes in and all they have is demyelinate, they've got loss of vibration sense and fine touch, and indiscriminate touch. I know that this is probably, and it's in all four extremities. I'm thinking cervical cord, posterior column, right? So putting these together is not only like what level and what signs and symptoms might I see, but also where in the cord could this be based on signs and symptoms. All right. So, okay, what are some additional examination items that you'd want that would be helpful for patients with cervical myelopathy? What other things could you do? So we talked about patients' hyperreflexia, right? So in the lower extremities, we could do clonus, right? You could just quickly test clonus. You do Babinski. Those would all be things that you'd want to think about that might be appropriate too. What's the approach? If you were the first person to see this patient, this was your grandparent, and they were saying, I'm having all these problems, and you're evaluating your grandparent, your grandmother, and you're like, I got these signs and symptoms. Yeah, we would want to refer this patient. Yeah, we'd want to refer this patient, right? For imaging and treatment. Now, we may treat this patient. They may get re-referred to us, but again, especially with these aggressive symptoms, you'd want to have this patient evaluated and MR'd, because you don't know.
Yeah, what? I'm listening.
It doesn't just mean that it's a cervical stenosis. There could be a tumor in the cord. There could be all kinds of different things. And so imaging would be really important. Okay, this is great work by Chad Cook out of Duke University, and that he did looking at a lot of different patients and what were those signs and symptoms. Again, if you've got 3 of 5 of these signs and symptoms, you can see that likelihood ratio, really predictive. So we talked about what are some different tests we could do. We would want to do Babinski's. We'd want, this patient clearly was older, positive Hoffman's, gait deviation, all those things qualifies for this diagnosis. This is a patient that, again, just to give you an idea, we'll see how this video runs on your end. But you can see this patient's so reflexive. I'm actually, normally when you do this test, you want to let the index finger and the thumb come together, right? She's got so much tone, I can flex her middle finger and cause all her fingers to go. And you can see here, this is a better way to do that with letting that finger go. All right. So again, in the review and study guide, we create these tables, and we purposely do this so you can compare and contrast across a lot of different conditions very efficiently. So in this case, again, we can look across this table and against a differential diagnosis, and we can compare ALS with diabetic chronic polyneuropathy, acute Guillain-Barré, an acute polyradicular neuropathy, and like conditions like myasthenia gravis. Okay, number 3. Twenty more seconds here. Okay, let's go ahead and we got a poll in there for me, if you would. I'm going to share the results. All right, results are up. Nice job on this question. So here we go. Let's take a look here. So this patient had initial evaluation and experienced a left anterior cerebral artery stroke 7 days ago. And remember, on this exam, if you're given time frames, that's a big hint. They're trying to get you to visualize that patient. So again, this is a patient who's going to have higher low tone right now. It's 7 days out, more than likely. Low tone, right? Early, acute, so low tone. And think about how they could spin that into a treatment type based question, right? So in this case, this is the left anterior cerebral artery stroke. That artery feeds right, if you look at on the picture or look at me here, right along your longitudinal fissure that goes right through your homunculus. And what represents your homunculus right there is your lower extremity and your genitalia. So in this case, this patient is going to have, and you guys crushed it, contralateral lower extremity hemiparesis, sensory loss, and bladder incontinence. That's what's going to be most consistent on this patient. So this patient, contralateral upper extremity flexor synergy and lower facial paralysis, this would be more consistent with a chronic middle cerebral artery stroke, right? Because it's upper extremity flexor synergy, meaning this person's high tone. If they've got high tone, you know, this has been going on for a while, not days, but more like weeks to months or longer. And then some lower facial paralysis, that would be consistent with a middle cerebral artery stroke. Contralateral upper and lower extremity hemisensory loss, tremors, and visual impairments. What kind of stroke is that? Number 3. Visual impairments with hemisensory loss. We think of a good job, a PCA, right? Posterior cerebral artery. And the last one, contralateral upper and lower extremity hemiparesis with ipsilateral tongue weakness. That would be a basilar artery stroke, and that would be in your brainstem. All right. Okay, so again, these are nice. This is out of the, again, you've probably seen these in different places, but this is out of the Reading Study Guide. And again, anterior cerebral artery stroke, that vascular zone's right here. That correlates to your lower extremity and genitalia. Look at this, your middle cerebral artery stroke. This is a devastating stroke. If you hit the main stem of your middle cerebral artery stroke, look at how big that area is. And that's going to that's going to be trunk, that's going to be your upper extremity, and then your face, all right, is all going to be involved. And then PCA, that's in blue. That PCA is going to be visual impairments from the occipital lobe. It's also going to hit your thalamus. That's a big part of that hemisensory loss. It can also get into your basal ganglion. So these patients can have Parkinson's-like symptoms also, or even choreiform type symptoms like Huntington's chorea, because those are both problems in the basal ganglion. So if you've got ischemia of the basal ganglion, you can get really bizarre symptoms that can also go along with the PCA. And then brainstem strokes, and we have those summarized in the book too. Okay, number 4. We're moving right along here, folks. Okay, another 15 seconds. Okay, pull in there for me if you would. We're going to end the poll. Share the poll. There we go. Okay, so Now we're going to a right middle cerebral artery stroke 2 weeks ago. So this patient is going to have, they've got, and they tell you in here, they give you those impairments. They've got contralateral upper greater than lower extremity hemiparesis and sensory loss. They give you no other impairments. And it asks you what examination item would be best to address the patient's primary impairments. So let's walk through these a little bit. So the FEM, right? The FEM is not required by Medicare anymore, but it is a tool that's still used. It's still one of the recommended tools that's been put out for use with, if you look at the different, I'll show you here in just a little bit, but if you look at the recommendations from the neurology section of the NPTE for different conditions, the FEM is often referred to. But the FEM, what's unique about the FEM, right? It has multiple domains. So if the question was said the patient is having problems with motor sensory impairments, cognitive impairments, transfers, mobility, and bowel and bladder. So all these different domains, the FEM would be a great measure, right? Because it measures a lot of those domains. The CARES tool, a lot of you that are doing your acute care rotation or already done that or doing a neuro rotation, you may have used the CARES tool too as another one. So again, that's one example. Somebody asked, is a FEM more for clinicians in acute setting? It typically is, yeah. It's used in acute settings, also used in rehab. So again, if you're doing it in a neuro rehab center or a rehab center in general, and it's a tool that you can track over a period of time. So not just limited to acute care, but also could be typically you'll see it in a rehab center. And it can be used in outpatient setting if it's appropriate. But again, hopefully by the time you get a patient in outpatient, some of the multiple impairments are starting to come down a little bit. So again, with these kind of items, then let's look at some other things. What the one on here, and again, 59% of you got it, the Fuglemeyer. The Fuglemeyer assessment of motor performance is a great measure to look at. It's called a motor performance, but it looks at sensory, it looks at motor, it looks at tone, it looks at your activities of that upper lower extremity. So the Fuglemeyer assessment of motor performance would be the best measure here because it is specifically designed to capture both sensory and motor perspective, motor learning perspectives, weakness, tone, all those things. All right. So somebody asks, is there a specific time frame to complete the Fuglemeyer by someone post-stroke? I think this is a measure that's nice because it transfers across both acute and chronic patients. So this is an assessment you could do on somebody even that had a chronic stroke that now is being referred to your outpatient clinic. So but it is. So it is a nice measure to use for sure, both acute and chronic. Oh, okay, yeah. And then the NIHI stroke scale. The stroke scale is also a nice measure, but it's typically used a lot of times in research. It is also, it's got multiple domains too. So the difference about that is it has multiple domains and it will, so again, it's not just going to cover just motor and sensory, it's going to cover a lot of different domains. So you guys probably have seen this a lot, so this is just so the neurology section has done a really nice job of doing what's called these EDGE task force, and they have this for stroke, multiple sclerosis, spinal cord injury, right? And it not only says what PT should use, but look at this, recommendations for patients with stroke, but students should learn to use. So again, these get updated. This one's a little dated that I'm showing you 2018, but these get updated periodically. And when they get updated, there's specific measures on there. So if you go, you don't have to be a section member. You can go neurology, Academy of Neurology Physical Therapy right now, search this, and you can pull down these measures. And where I'm headed with this is, again, this says students should be exposed to. That's a lot of things to remember. Like, look at this, NIH stroke scale. Some of these things you may not have known, and you're like, can you go over that? Don't beat yourself up. I would say this, really important, you definitely want to know these. And so again, like some of these, like stroke impact scale, if you haven't done an acute neuro rotation, you may not be using this that much. So this is one you pull down on your studies, make sure you want to look at. But you want to look at these measures that are recommended on the EDGE task force. And then again, as you go through these, it's kind of appropriate, like what do they measure, right? You want to focus on that. The core measures, this is for any patient that's undergoing neuromuscular rehab. These are typical measures that can be used. So these are, we call them kind of the big six, but these can be used for most patients. So you can imagine, you want to feel comfortable, and I know you do with these. And this, just again, to put this in perspective, different pathologies, right? So for the examination questions, because we get questions that are examination questions, we get evaluation, differential diagnosis, prognosis questions, or we can get intervention questions. examination questions, you want to go through those different primary pathologies and feel comfortable with the, especially with the ones where it says should learn to use. Make sure you feel comfortable with those. All right. Okay. Number 5. Okay, we'll go another 20 seconds. All right, we'll go another, let's go another 10 seconds. Go ahead and pull in there. All right. Okay. Nice job. So a lot going on in this question. Again, this is a lot of information. You could build some other questions off of this, but this patient has sensory loss and fatigue, right? They got referred for balance. And I see this a lot where patients will get referred to PT because of balance and please assess for balance, and you assess for balance and you start going, well, this isn't, yeah, the patient's got a history of diabetes, but there's more going on than diabetes, right? There just doesn't fit just polyneuropathy. And so when you look at this patient, you realize that they have a lot of different things going on. So again, they have visual changes. They're talking about fatigue. Those are the two primary uh, reports that you hear from patients with multiple sclerosis, right? Visual changes and fatigue. They also have a kind of a unique sensory loss. And I kind of hit on this a little bit earlier. They've lost vibration, monofilament, and proprioception distal to the bilateral thigh. So meaning this is the patient that says, I just don't like, I can't really feel my legs. Like if I get touched with a sharp object, I know I'm being touched and I can kind of sense that, but I can't really, like in general, my legs feel numb, and they'll use the word numb. I mean, the word numb means you just don't feel, right? The word tingling, burning, that's more small fiber, spinal thalamic type pain stuff, right? This patient can sense a painful stimulus. They can't do that with another one, which tells you this is limited to large myelinated fibers. So in this case, this patient has multiple sclerosis, and we're going to talk a little bit about that sensory loss and where that's at too. Why not Guillain-Barré? Because it would be rapid. It wouldn't be over the past year that it's progressed. It would be within days to a week or 10 week to 10 days quickly, maybe 2 weeks that the patients will get rapidly weak. Chronic polyneuropathy, we talked about that. This patient, again, doesn't fit that. It doesn't, you could kind of argue, and myelopathy again, and we're not seeing what with myelopathy, we're not seeing upper motor neuron signs and symptoms. So what you can say about this patient, so as we look across this and we think about it, this is, again, just another picture of those different conditions that you can see and we talked about. In this case with MS, I'll ask you, where do you think this lesion is? The lesion that's causing the sensory loss? What do you think that right? Because, right, multiple sclerosis happens because of demyelinating plaques in the central nervous system, anywhere in the central nervous system. Where in the central nervous system do you think this demyelinating plaque is? Got complete loss of sensation, distal to both thighs, all the way to the toes. Okay, could be brainstem, could be, yeah. Let's think it's bilateral, right? If it was, and if let's talk a little bit here. If it was, oh, there we go. Everybody look at Emily. Sorry, Emily, I'm sorry for pointing you out, but you're right. Posterior spinal cord, right? If it's both limbs, right? And if it's both, it's got both lower extremities. And we think about this, let's look at this again. That somatotopic organization of your spinal cord is not only does the posterior column fit with all the sensory loss, but look at this, it's somatotopically organized, meaning that if you put a demyelinating plaque right here in the middle of the cord and put it right there, you're going to get sensory, both lower extremities are going to be weak. And guess what? This plaque is up in your cervical spine, which is a very common place, upper cervical spine, to have demyelinating plaques with MS. And again, sensory loss, because look at it, all that's white matter, right? And MS unfortunately just loves to attack white matter. So again, this is an example of a patient that, again, that demyelinating plaque can give you those signs and symptoms. And then the other signs and symptoms that are happening because of other random plaques throughout. So I think MS is the hardest diagnosis from neuromuscular conditions, because if you say, well, we know about fatigue and visual loss, but all the other signs and symptoms, again, cognitive loss, anything in the brain or the brain stem or the brain or the spinal cord can be reproduced by a demyelinating plaque. So it often gets missed, and patients get other diagnoses before you finally figure out what's going on. So if you're reading a question and they're giving you all these random signs and symptoms of burning in one arm and tingling in the other arm and visual loss and fatigue, you're like, yep, MS, which you guys did great on this question. Okay, so this is another example of examination items. So, when we read about these, this is spinal cord. So again, organized for spinal cord, what do you need to know? These are the ones you definitely got to learn how, all these. So when you're thinking about a spinal cord examination level question, these are all things that that the association is recommending that you go through and feel comfortable with. And then again, these are other ones that you can look at here too. So just being familiar with those. Okay, team, we're getting there. We're getting close. I'm going to restart the poll here. Okay, we're going to go about another 20 seconds. So this is an examination question, right? They give you the diet, they give you what the process is, or the pathology. And now they're asking you, okay, in this patient's primary concern is lower extremity fatigue. That's what they're coming in with. What is the best outcome measure to track this patient's lower extremity fatigue? So myasthenia gravis, if you evaluate a patient with mild to moderate myasthenia gravis, and you do your neuroscreen, your lower extremity neuroscreen in this patient, is it going to be normal or abnormal? If you test their sensation, their reflexes, and their strength, do you think it's going to be normal or abnormal? Everybody, yeah, fire out there. What do you think? Yeah, it's going to be normal, right? Because what do we do with muscle testing? We do 1 rep. So you test this patient with 1 rep, they're going to be normal. And so normal, that's going to be, you kind of do your neuroscreen. You go, okay, well, I know it's not some other conditions, right? I'm ruling that out. But now if you do repetitive testing, especially of proximal muscles, if you fatigue out proximal muscles, because this is what happens in myasthenia gravis, typically affects, right, oral facial first, and then it moves its way into proximal muscles, like your deltoid scapular girdle muscles and your pelvic girdle muscles, glutes and quads, before it gets to your distal muscles. So in this case, and again, not an easy question, and you can see kind of the spread of options here. The correct answer here is actually number 4, 5 times sit to stand. And the reason is because, right, more proximal muscles. So if you work this patient and you have them up, down, up, down, up, down, up, down, and then retest them, you're going to see fatigue. So again, I don't disagree. If you do a 6-minute walk, you're going to fatigue them out. But just doing these proximal muscles, repetitively stressing these proximal muscles, is going to be more of probably a sensitive indicator for what's going on with these patients. Because think about it, walking, I'm not saying, obviously walking involves proximal muscles, but it's also a lot of distal muscles, right? It's a lot of your tibialis anterior, your gastroc. Those aren't going to fatigue out right away. They're going to take a while unless the patient has really severe myasthenia gravis. So another option there. So 5 times sit to stand, good test. In what would be upper extremity, you could do the same thing with the upper extremity, just having them bring their arms up over their head repetitively and then testing. So what would you see in this patient if you just walked up to this patient and looked at this patient? What's one thing you might, even with mild to moderate myasthenia gravis, what's something you might see if you look at this patient? Sunken eyes, good, right? Ptosis, so partial ptosis. They won't have complete ptosis, but they'll have a little partial ptosis. They'll have the eyelids will be drooped down, and you say, Mr. Johnson, can you open your eyes all the way? And he says, I am. That's as far as I can get him. That's as far as I can open them up. And so you can do there we go, Sarah, ice pack test, right? Close the eyelid, put ice on there, hold that for 20, 30 seconds, minute, pull it away, and ask the patient to lift their eyelid. And it's like magic. All of a sudden they can lift it completely. About 30 seconds later, it's going to start to droop down again. So again, why do these muscles fatigue out? Is because if you think about the innervation ratio, it's like one little nerve fiber to about 1 to 2 muscle fibers. So there's, these our eye muscles fatigue out really quickly. And specifically that lid can fatigue out. So don't be surprised, even in a patient with mild to moderate, this is where, again, they're coming in for lower extremity, but you're going to have to do a cranial nerve exam, right? You're going to have to check it. So this is where, being able to tell, like, this is not the normal presentation. What's some other things I want to do? I want to test some cranial nerves. All right. And definitely look at that cold pack test. Nice job. So again, going back to those core measures, in this case, this is where 5 times sit to stand. What's another neuromuscular condition that presents with proximal weakness that would be good, that a 5 times sit to stand would also probably be another measure that you could use to pick up on some weakness? Yeah, good. Myopathies, right? So myopathies start proximal and move distal. Neuropathies do what? They start distal, move proximal. So always remember, that's myopathy is another one that would have fatigue with this. Okay, last question, team. Here we go. Let's go another 10 seconds. All right. We got a lot of people that have pulled in. You guys are crushing it. Oh, I'm sorry. My bad. My bad. I'm like, wow, that's great. Let's do this again. There we go. Go ahead and pull on in there. All right. Before I just jump on, there's a question on there about myopathies, and I want to just repeat that. Yeah. So myopathies, last question, myopathies start in proximal muscles, then they progress down to distal muscles. like diabetic neuropathy, alcoholic neuropathy, any kind of polyneuropathy starts at distal, moves proximal. So it's just a good one to remember if you're getting those kind of descriptions in the question. All right. So here we go. Last question. You guys, again, ending super strong. So this patient has what they come in and this is always, I always get the hair on the back when I get, I get patients. We see a lot. I work in, again, neurosurgery clinic we have 2 spine fellows. So we see a lot of spine conditions, but we see a lot of all kinds of different things. And, but when a patient comes in and just says, I'm weak, I always get kind of worried because, again, why? If they're not, and I'm like, are you sure you don't have any numbness and tingling, any tingling, any burning, any radiating pain? And they're saying, no, I'm just weak. This is where you get really concerned because you start thinking about, is this a myopathic condition? Is this, and then again, part of your differential too needs to be ALS. So in this, especially if the patient's talking about muscle spasms, and the reality is with ALS, you got a lower motor neuron problem and an upper motor neuron problem, meaning that you're going to have fasciculations in the muscle. Literally, you're going to be able to see the muscle fasciculating, and you're also going to get spasticity because of the upper motor neuron problem. So these patients have they'll come in and say, I've got all kinds of muscle cramps, or I feel my muscles twitching and cramping. In this case, you've got sporadic and kind of, it doesn't fit a it doesn't fit a myotome or a nerve root distribution. It's just kind of extensor hallucis, left tibialis anterior, right first dorsal interosseous. You're like, okay, now all of a sudden it jumps up into the hand. And then you're testing reflexes, and on the opposite sides, you've got these 3+ reflexes. So with early ALS, you're going to see sporadic findings. And often in ALS, unfortunately, patients will come in with intrinsic hand weakness, and it'll look like it's mostly in their ulnar nerve. And then they'll say, oh, yes, an ulnar nerve problem. And then 3 months later, the patient says, well, I'm having a really hard time walking. And they'll go look at the back and they'll say, oh, you got a lot of arthritis in your back. But that's where you just got to step back and say, well, there's no sensory findings. That doesn't fit with like radiculopathy or anything. So in this case, you guys, again, excellent job. This is ALS, Lou Gehrig's disease, and a classic of upper motor neuron findings without sensory. All right. So again, just kind of highlighting those areas, what stands out about that. Those are things you think about. Yeah, good question. So the question on there, would you be more likely to consider polyneuropathy if there was no spasms? Yeah, if the patient, and again, you can get, right, I mean, you can still get fibrillations with polyneuropathy because that's a peripheral nerve problem. It's destroying motor axons too. So you can still get fibrillations and fasciculations, right? But you're not going to get the upper motor neuron part. So yeah, if you're not getting spasms or you're not seeing, and this is where just being really good with your reflex testing. Is it hyper? Is it not hyper? Being really good, making sure you do a Clonus, do a Babinski, do a Hoffman's, go through those steps. If you see people, especially with 4-limb presentations, you always want to go through that, do uppers and lowers and check. So yeah, great question. All right. So again, these comparison charts, again, as you're thinking about differential diagnosis, this is the example of the central nervous system, different ones that I'd show you. So we talked about stroke. We talked about different examples of spinal cord, right? And we talked about, somebody who has cervical myelopathy and stenosis versus somebody who has a demyelinating plaque in the cord. We didn't talk about Parkinson's, and we didn't talk about cerebellar. So those are ones you can think about, but yeah, there you go. Yeah, good question. There's so many symptoms. Is there a way to not be overwhelmed? I got really confused on this one. Yeah, you're asking a wonderful question, and there's a lot going on. And what I would say, as you approach these questions, I always kind of look at. I'm reading through it. I'm reading. Okay, what are the muscle problems? Are the muscle problems more tone, high tone, or low tone? And are they more weakness? That fits more with a lower motor neuron problem, and then I kind of think, oh, peripheral nervous system, or is it more spasticity? Okay, or Hoffman's, that's upper motor neuron, central nervous system. And then I think, okay, now what are the sensory symptoms? So I kind of break them out, break your symptoms out, sensory symptoms. Okay, is it more straight up numbness and loss of vibratory sense and monofilament testing and touch, or is this a problem of burning, tingling, more spinal thalamic tract? More areas that would make me think about small nerve fiber problems. So that's kind of in the way to kind of think about it is just pull back a little bit and go, what do I do in my neuroscreen? I do reflex, I start off with sensory and motor by doing strength and sensory testing, and then I bring that together looking at a reflex loop, right? And then I do my special tests. Like when I think of when I say special tests, special neurological reflex tests like Babinski clonus, those type of things. So keeping those compartmentalized just like you would an exam. And as you do that, then step back and look motor, look sensory. Because a lot of times if it's straight up motor, you can eliminate a lot of conditions right away, which can be helpful. So hopefully that's helpful. All right. We are 3 minutes left. I'm going to go ahead and let me just come here and I will stick around for a little bit if there's any questions. So let's, I know some of you have had your hour and you're in and you're like, my brain is full. I'm going to go ahead and bring up all the screen so I can see you guys. So again, if you hope you enjoyed, give me a, if you don't mind, turn your cameras on, give me a wave before you take off. That way, when I see you at CSM next year, I can say goodbye. Thanks for coming online. Awesome to see y'all. You got this test. Crush it. Take it down. All right. And I'll stick around if you guys have any questions. Thanks for coming online. All right. All right. Somebody asked me about the Hoffman's test, so I can go back to that one. All right. You guys got to hold on to your screens here a little bit. I'm going to go back. I don't want to give anybody vestibular disorder here. Let me go back to this one here. There we go. So, so let me move some stuff out of the way here. So the Hoffman's, now this is, I should be letting this finger go free and I should just flick this middle nail. All right. Yeah, you're welcome. Thanks so much for coming online. But watch this. So when let's hit this slide. So watch this. So all you're doing, now notice I bring the fingers up a little bit just to get a little stretch. Because if you read the book, a lot of times they just say, if you flick the top of the nail, you're going to get this big response. You have to have a lot of spasticity to do that. So a little way to sensitize that is bring those fingers up a little bit, put them in a little bit of flexion. And then you can see how all of her fingers are curling together, even her little finger. And I was just doing that to show she's got a lot of, that's a positive plus Hoffman's. There's a lot of tone there. Now, if I come to the other side, now the thing that's telling here too is, right, she's got signs on both sides. Both sides. So when you see it on both sides, you know there's a lot going on. And I always think to myself, that's more consistent with the cord problem. If it's a brainstem problem, or excuse me, if it's a stroke, a cortical stroke, I'm going to typically find a Hoffman's on one side, but I'm not going to necessarily, I shouldn't find it bilaterally, right? Because it's only in these tracks. It's not both sides of your brain. Doesn't happen, fortunately. But if it's in my cord, I can get a bilateral Hoffman's just like that because the cord's a small little space, hit those upper motor neurons, and you can get them both. Yep. So hopefully that was helpful. And then other questions. What other questions? You can come off the mic or you can chat if you have a question. Yeah, again, if somebody had said a little anxious, you can do, yeah, absolutely, you can do this. You got this. Yeah, you got this. And again, I'm going to say these were not easy questions. These were compare and contrast with a lot of different signs and symptoms. So you want to, you know, this is, you guys did really well on the questions though. Good job. All right. Any other questions for me? Can I go over the last question? Yeah, absolutely. Let me do one thing here. I'm going to